Good afternoon, everyone.
Good afternoon.
Myself, Dr. Vinod Kaushik, on the behalf of IIP India Digital Team, just welcomes all of you. I just show my gratitude towards Dr. Sanjeev K. Jha, IIP President, and Dr.
Mhm.
Ruchi Vasan, IIP Women's Cell National Head, for providing us a wonderful webinar, for
Mhm.
sharing the knowledge. Today, the webinar, the topic Hormones, Women, and Exercise, is organized by IIP Women's Cell and IIP Delhi. And the topic will be taken by Dr. Abha Sharma. And the today moderator is Dr. Sandhya, Dr. Dipti, and Dr. Shikha. I just request everyone, please subscribe IIP India YouTube channel and Facebook and like Facebook page IIP India. I just now hand over to Dr. Dipti. Please continue with the webinar.
Dr. Deepti, your mic is on mute.
Good afternoon, everyone, and a very warm welcome to you all. I am Dr. Deepti Sethi Bhasin, Senior Physiotherapist in Charak Palika NDMC Hospital, and today I'll be your MC and moderator for the webinar organized by IIP. I think this Corona epidemic has challenged us in in a very different way, and it has come as such a jolt to our lives. It has taken us all by lot of surprise. It has really, we are all facing with very difficult times. It is unexpected and unprecedented, but the silver lining and the saving grace is that we've learned to live our life in a different way. New things we have innovated, we have innovative ways to come up and cope up with the calamity. And a very good example and a very great initiative is good example is taken by our IIP India, that is this virtual webinar. And I for that I think I would like to thank our president, Dr. Sanjeev Jha, being the flag bearer of this organization, Dr. Ruchi Varshney, who is our IIP Women's Cell President, Dr. Deepti Goyal, who is the North Zonal Head President, Dr. Nidhi Kalra, she is our head for the Delhi team, and Dr. Sandhya, who is our district coordinator, me, that is Dr. Deepti, and Dr. Shikha being your sub coordinator for Southeast Zone. And now, without wasting any further delay, I think I would like to welcome our main speaker, the chief speaker, that is Dr. Abha Sharma, who is a chief physiotherapist in Holy Family Hospital. She'll enlighten us about the hormones, exercise, and women, that topic. Please, ma'am, please take it.
Good afternoon, everyone. At the outset, I would like to thank all the organizers, Dr. Nidhi, Delhi State Coordinator, and IAP WC Southeast District in charge and officiating in charge of PCIP, as well as Dr. Sandhya, Dr. Deepti, and Dr. Shikha for inviting me for today's webinar and cooperating with me for the past few days. I'd like to say I have known Dr. Nidhi Kalra for the past few years, and I personally admire her dynamism and dedication for the profession. Now, I also would like to thank the IAP core team members and all the senior officiating members for giving me an opportunity to be here with all of you today. So we keep talking about exercise, fitness, health, women, immunity, hormones. These are the common words which we have been using all throughout in the past couple of months. So exercise and fitness is not just about losing weight, toning up, looking good. It is more about improving one's health physically, mentally, and emotionally. So it's about fitness fusion. It is physically being fit, able to think better, and able to feel better. So let's all aim at fitness fusion. Exercises are an integral part of women's health. They improve our quality of life. And so I've just taken 4 small topics, that is dysmenorrhea, obesity, PCOD, and menopause. The role of exercises in these few conditions we'll be discussing. I'll just share the screen. for many women to improve our quality of life as well as immediate and long-term health benefits are there. Now, what do we think are the importance of exercise? If I put this question for all, could I have a people responding? How do we exercises help us? Okay, exercises along with giving us better sleep, improve bone density, better weight management, reduce risk of diabetes, decrease blood pressure, improve lipid profile. It is about holistic multitude of health benefits. The role of exercises in dysmenorrhea, we'll be talking more about primary dysmenorrhea, obesity, PCOD, and menopause. So what exactly is dysmenorrhea? Now it is derived from the Greek word meaning difficult menstrual flow. At some point of time or the other, most women at some cycles or a couple of cycles have undergone dysmenorrhea. So it is an acute cramping pain in the lower abdominal and the pubic area, back pain, increased intestinal motility, headache, nausea, dizziness, anything could be accompanied with the pain. In severe cases of dysmenorrhea, there is absenteeism from school, work, inability to even do our normal household activities. So, dividing it into two categories, primary and secondary dysmenorrhia. This primary is painful menses with normal pelvic anatomy. Usually, it begins a few years after adolescence when the ovulatory cycles have begun. Associated with identifiable secondary is when there is an identifiable pelvic pathology many years after MENA. So primary dysmenorrhea onset is usually shortly after MENA and secondary any time after MENA. The associated symptoms of backache, headache, diarrhea, nausea, vomiting is more commonly associated with primary, whereas with secondary menorrhagia, metorrhagia or dyspareunia could be seen. The lower pelvic or abdominal pain associated with the onset of menstruation is more common with the primary, and with the secondary, could be any change in the time of onset of pain and intensity of pain can vary with the menstruation. So, recurrent cramps occurring immediately before or with menses in adolescence after the establishment of the ovulatory cycle caused by myometrial activity lasting for a few minutes and producing a pressure of more than 60 millimeter mercury, resulting in uterine ischemia. The myometrial activity is modulated and augmented by prostaglandin synthesis, which triggers the contractions in the uterine and the intestinal walls. So, the pain and severity, the spasms or the intermittent spasms of pain which come, they could start from 1 or 2 days in mild cases and continuing up to the first 2 days when the flow is the heaviest, or in some cases, in severe cases, it could start 6 to 12 weeks before the onset of menstruation and last up to 2 to 4 days of the cycle. So what exactly happens? When the egg is fertilized, If the egg is fertilized at the mid-cycle, then the levels of the progesterone go up, the corpus luteum is formed, and the progesterone levels are increasing. If the egg is not fertilized, then gradually there is going to be a decline in the progesterone levels, and there is going to be an increase in the prostaglandin synthesis, which is being caused by the endometrium, which has to be shredded out. So this increase in prostaglandin causes an increase in the myometrial contractions further leading to ischemia in that area. So increased uterine activity as well as uterine ischemia causes sensitization of the nerve terminals to prostaglandins, which causes the pain. So excessive production and release of prostaglandins during menstruation by the endometrium, causing a hypercontractility of the uterus, leading to uterine hypoxia and ischemia, is responsible for the pain and the cramps in primary dysmenorrhea. So there are various pharmacological therapies which can be available, and among the non-pharmacological therapies, what is important for us are the physical therapy interventions. So from heat treatments like superficial heat modalities, hot packs, or TENS, relaxation techniques, aerobic exercises, manual physical therapy, stretching exercises, and connective tissue massage could play a role. So the general benefits of exercises in dysmenorrhea, they could have non-specific analgesic effects by improving the pelvic blood circulation and stimulating the release of beta endorphin. They could be a general improvement in the mood, reduction in the stress or the mental pressure, a decrease in the percentage of the body fat. Obesity is associated with an increased prevalence of dysmenorrhea. So brisk walking up to 30 minutes per day on, on a regular basis, and even on the first 1 or 2 or 3 days of this cycle has shown to reduce the severity of primary dysmenorrhea and the menstrual pain. So it has been found that athletes who are regular with 3 sessions of exercise per week have less incidence of dysmenorrhea than the non-athletes. So pelvic tilting, walking, cycling, swimming, they all are known to provide benefits, improving the blood flow, relaxing as well as strengthening the abdominal muscles, reducing pelvic pain, and relieving the pressure on the nerve centers, pelvic organs, and the alimentary canal. Stretching exercises, they help in vasodilation, release of endogenous opiates, improving flexibility and restoring mobility, relaxing the tense uterine muscles, maintaining good abdominal tone. So that daily belief that contracted ligamentous bands in the abdominal region were the causative factors for physical compression of the nerve pathways and their irritation. The series of stretching exercises was considered effective. The core stability is also important. So doing physical activity for more than 3 times per week reduces the dysmenorrheal somatic symptoms during the menstrual period in women. So what is important is to have a regular, consistent approach of exercises. So as growing up girls, trying to help them to reduce weight or maintaining a healthy body weight, rather than to discouraging them with the onset of menstruation to stop being physically active, to putting them more indoors. So we should get away with that, keeping them physically active, keeping their weight and body changes under control as we see as we move further, how that will also help in them to have a normal hormonal cycle. So obesity.
Yeah.
Now we all know that excuses don't kill the fat. It is the exercises which kill the fat. So in a simple classification of obesity, based on body mass index, if we see that underweight are when the BMI is less than 18.5. Normal weight when it is 18.5 to 24.9, overweight when it is 25 to 29.9, and obese when it is more than 30. Morbid obesity between the three classes is when it is more than 40. So there could be various reasons for obesity to take place. They could be a genetic as well as a lifestyle pattern which could lead us for hormonal changes and which could also exacerbate the obesity within us. If the genetics and lifestyle, they both bring about hormonal changes, with genetics there is an increase in the androgen levels. This increase in the androgen levels can cause an increase in the circulating insulin levels. The increase in the androgen can lead to hirsutism and acne. Increase in the androgens can also lead to an impairment of our ovarian follicle development, which will lead to menstrual disturbances and subfertility. Increase in the circulating insulin levels can lead to diabetic metabolic syndrome as well as impaired ovarian follicle development. The diabetic metabolic syndrome will further lead to increased cardiovascular risk. With all these things, the psychosocial image of the women also, or the growing up girl also starts getting affected. She is more conscious about her body image, her self-esteem. It could lead to depression and anxiety. It has been found that the incidence of menstrual disorders is lowest when the BMI is within the normal range. It doubles when the BMI of 24 to 25, that is borderline going towards overweight category, and it becomes 5-fold higher in those with a BMI of 35 or more. So with increasing BMI, there is an increased insulin resistance and diabetes, increase in the risk of coronary artery disease, and increased waist to hip ratio. This increases the incidence of menstrual disorders and infertility. It has been found that women with a waist circumference of more than 35 inches are more prone to develop various menstrual disorders. For men, not talking about menstrual disorders, but for other risks for men, this thing in men will become 40 inches. So the impact of obesity on reproduction starts at a much younger age. Obese girls can experience the onset of puberty at a younger age than their normal weight years. Polycystic ovarian syndrome frequently causes menstrual irregularities and is very common among women, though the actual prevalence is unclear. There is a link between obesity and type 2 diabetes also. The risk of diabetes increases with a degree and duration of being overweight or obese, and with the central or the visceral distribution of body fat. Increased visceral fat enhances the degree of insulin resistance, which becomes the hallmark of metabolic syndrome. So with metabolic syndrome, there is a chance of having erratic or high blood sugar levels, deranged blood pressure levels, deranged lipid profile levels, and increased risk for cardiovascular problems and stroke. So since we're talking about insulin resistance, what actually is insulin resistance, which we said in obesity and which we'll be saying in PCOS? Now, when we eat something, whatever little amount of glucose is there within that, our body normally secretes insulin from the pancreas to digest that glucose, what we have ingested. In the case of insulin resistance, what happens? For the same amount of intake of food of glucose, our body needs higher levels of insulin to be secreted to use that glucose. So with a large amount of insulin is needed to push the glucose into the body tissues. So in a healthy person, there is a normal level of glucose in the blood being digested by the insulin. But when there is an insulin resistance being developed, there is an increase in the level of glucose in the blood still there even after being utilized, because more than normal amount of insulin has been thrown in and still it is not being able to properly utilize. So gradually we will be replenishing the insulin store. So
Dr. Abha, I have one question.
Yes.
You told some metabolic syndrome. Can you explain what is metabolic syndrome?
Metabolic syndrome is when we'll be going into a deranged metabolic parameters of having higher blood sugar levels, higher blood pressure levels for our age, increasing our risk for cardiovascular diseases and stroke, and having altered lipid profile. It's not that we are gradually moving towards the range where we will have metabolic problems and we will fall into the category of diabetes or hypertension or increasing our risk for other problems. And even sometimes it could then push us towards hypothyroidism.
ओके थैंक यू सो मच। मुझे पार्टिसिपेंट से भी रिक्वेस्ट करनी थी, अगर आपके कोई क्वेश्चंस होते हैं तो प्लीज आप चैट बॉक्स में अपने क्वेश्चंस कर सकते हैं। थैंक यू डॉक्टर अभा, आप कंटिन्यू कर सकते हैं।
So whatever exercises we are taking, whether it be aerobic training or resistance training, both will help us to reduce our metabolic syndrome. So aerobic or interval training will help improve the insulin signaling in our body. Resistance training will help improve the insulin signaling as well as increase our lean body mass. Both of these will make us more insulin sensitive. That is, our insulin resistance will come down. We will not be requiring more than normal amounts of insulin to be pushed into our body, and with reducing insulin resistance or improving insulin sensitivity, our incidence for metabolic syndrome comes down. So there is also a link between obesity and coronary artery disease. So it becomes an independent risk factor for development of CAD in women, and it is the most modifiable factor for prevention. There is, in this, the relation is both between obesity as well as in insulin resistance. It has been found that abdominal obesity is more harmful in women than BMI or weight alone. So with abdominal obesity, there is an increase in the circulating levels of insulin, which would lead to increase in ovarian androgen production as well as increased functional androgen levels, causing suppression of 6 hormone binding globulin synthesis. And a chronic elevating circulating estrogen will cause hyperandrogenism, menstrual cycle abnormalities. It could be anovulatory cycles, subfertility, and reproduction difficulties could be there. So what again becomes important is weight loss. Weight loss through exercise. It is along with exercise, it will be our healthy eating pattern also, but exercise becomes important. So initial management for even infertile, overweight and obese women is weight loss. With weight loss, it helps to restore normal menstrual cycles. Fertility levels are improved. There is return of spontaneous ovulation and improved elevated levels of androgens and luteinizing hormones. When the level of LH is high, our incidence of infertility increases. So increasing LH and increasing infertility. So if the LH is brought under control, the fertility levels will be also brought under control. Even if we are not able to achieve the ideal weight for our height or for our age, if we are able to bring down our weight or be consistent with our exercise, it will achieve normal hormone levels. It will improve the ovulation and the menstrual cycle, and the fertility will be enhanced. Obesity has been associated with pregnancy-related complications, increased risk for birth defects, There could be multiple congenital deformities, and hyperinsulinemia becomes an independent risk factor for neural tube defects. So when we know all this, we need to take care of ourselves, then only we'll be able to take care of our patients. So obesity and cancer in women also have a risk. Endometrial carcinoma strongly related to obesity. It has been seen with obesity and menstrual disorders in the adolescence and reproductive period. Normal menstrual cycle is considered as a cycle of 21 to 35 days. So anyone who is having a cycle after 21 days or who is having within 35 days will be considered as a normal menstrual cycle. Anything less than that or more than that is what we need to consult our doctor and find out the cause and take whatever prevention, precaution or treatment for that. So both overweight women as well as underweight women have been found to have abnormalities in reproductive function, that is menstrual disorders, infertility or abnormalities in pregnancy during labor. So to keep the weight under check or to improve the weight if underweight with exercises gets important. So keeping all these facts in mind, exercises become an essential part. Both resistance training and aerobic forms of exercises are important. Consistency is important. So diet, exercise, behavioral modification are all that is important. Exercises speed up the glucogenolysis in muscles and liver, the citric acid cycle, oxidative phosphorylation in muscles, glycolysis in adipose tissue and muscles, and fatty acid oxidation in muscles. So we need to know how much exercise to be healthy and away from the onset of the metabolic syndrome and to have a lot of health benefits. What is required is to be doing exercises consistently for a minimum of 150 minutes of moderate intensity exercise per week. Now, if we look at it 150 minutes, it is, even if we exercise for just 5 days a week, it is 30 minutes for 5 days is 150 minutes of exercise. We need to squeeze out some time which we spend on unnecessary WhatsApp, Facebook, social media, idling away our time, and we can squeeze out those 30 minutes for ourselves. For effective weight loss, we can do approximately 225 to 420 minutes of exercises per week. So if we are so regular, so conscious, we can do 1 hour, 60 minutes, 7 days a week. Or even if less than that, even if we are doing for 90 minutes wherever possible, for 4 days a week, 3 days a week, we will be in this category. 45 minutes per day for 5 days will also mount up to approximately 225 minutes of exercises per week. So for weight loss and prevention of vegan, 250 to 300 minutes per week should always be maintained. Both endurance and resistance type of exercises will be helpful. They are effective for both body weight loss and they ensure high energy expenditure with the endurance exercises. With resistance exercises, weight management protocol, and reduction of the fat levels will be there. But we need to do a mix and match of both the exercises. For obese people, they can start with moderate intensity and they can increase up their exercise by 5% of exercise intensity every 6 sessions up to 65% of their maximal capacity. So a frequency of 5 days per week or more of aerobic exercises, moderate to vigorous intensity. Those with a BMI of more than 35 should avoid doing vigorous exercises as it may not be very appropriate to start with them for their joints. And for them, the vigorous training of exercises should be advanced very gradually, initially over a period of 4 to 12 weeks doing moderate intensity and then pulling up the level of their exercise. So 45 to 60 minutes of moderate intensity exercises are done each day or even 5 days a week to start with. They will have health benefits for us. And to avoid regaining of weight, we can push to up to 1 to 1.5 hours of activity per day. And walking also is an excellent form of physical activity for overweight and obese. It may not be running or jogging initially because they could jar up their joint, but at least walking they can start with.
Dr. Abha, can you explain one more thing? What is the importance exercises for adolescents girls? Can you explain?
Adolescent girls should be more involved in regular physical activity and aerobic kind of exercises. It's like they can do walking, running, skipping, jumping, doing jumping jacks. Along with it, they can improve their body flexibility by doing yoga. Rather than doing resistive exercises by weight, they can use up their own body weight in various yoga positions and what we call as weight bearing exercises in our physio session. They can do that, incorporate that, and improve towards a healthy weight and a healthy body structure.
Okay,
thank you. For those involved in sports, all sports including swimming, badminton, kho-kho, basketball, they all involve, they would improve their endurance as well as their resistance capacity by these sports also.
Okay.
And one thing I would like to ask is, does these strength exercises and cardio exercise, how do they affect the secretion of hormones? Do they affect differently? What is the exact difference between the cardio exercises and the strength training exercises?
There have been studies done for hormonal changes with menopausal and all, and they have found that some studies refute that they don't have an effect, that they don't have that much of an effect, or they don't bring down the estrogen levels. But a lot of studies say that exercises have a healthy role in reducing the level of estrogen in the body. Immediate effects are there. So once that is brought under control or the level is balanced, then the incidence of gaining weight or abdominal weight around our lower abdominal keeps coming down with the balance of the hormones.
That is it. Thanks, ma'am. Thank you. You please proceed, ma'am. You please proceed.
Yeah. Dr. Abha, sorry. Two questions in chat box. One question is, what kind of exercise we can do during the periods?
And during periods, you should avoid doing heavy activity, doing resistive training, pushing and pulling heavy weights, or lifting any heavy weight. But during periods, what you can do easily is you can enjoy walking. Walking is something, and gentle activity should be encouraged during the period. Unless and until you're having severe menorrhagia, severe flow, severe clots are there, that any kind of activity is increasing these symptoms. But otherwise, during periods, you can do that. And girls who have an athletic frame or who have been regular with their exercises, if they continue that, except reducing the intensity a little bit, they could do any form of exercise. But maybe running, jogging, weightlifting. And in yoga also, if the girls are into yoga or if they have taken that as a side-by-side thing, even in the first 3 to 4 days of this cycle for yoga, all inversion postures, where the legs go up, like Sarvangasana or Shirshasana, all those are not to be done where we are going to have or severe exercises where we will put our abdominal muscles into heavy activity. But walking and light activity are by far the best things which can be done if they're not having any problem regarding to their flow.
One more question. उसके बाद फिर हम आगे कंटिन्यू करेंगे. After menopause, which exercise is better for the person? Normally females को ये problems आती है कि कौन सी exercise करनी है.
We will be coming to menopause and we will be discussing this. But
during
and if it's not there in the slide, I will discuss it otherwise. So with PCOD, that is polycystic ovarian disease or polycystic ovarian syndrome, the most common endocrine disorder in women. And in the past couple of years, when we were young, small, growing up, we had never heard much about PCOD. But in the past few years, there is so much awareness about PCOD everywhere amongst normal people in the newspaper columns, within doctors. So what is there? It is a lifestyle change also which has increased the incidence of PCOD. So the symptoms may include irregular or absent periods, facial hair or hirsutism, central abdominal or visceral obesity. If untreated, it can lead to various metabolic incidences like diabetes, heart disease, or uterine cancer, and can cause infertility. What really happens in a polycystic ovarian syndrome is, in the case of a normal ovary, once the primordial follicle, there is a normal follicular development of primary follicle, secondary follicle, mature follicle, ovulation. But in the case of polycystic ovary, just to put it simply, the normal development of the follicle is impaired. There are multiple immature follicles are seen. So with it, there is weight gain, skin problems could be there like acne, oily skin, irregular periods could be there. Usually the cycles are delayed. Infertility chances are higher, incidence for high blood pressure, and increased insulin resistance. So it was a condition first described by Steen and Leventhal in 1935 by amenorrhea, infertility, hirsutism, obesity, and ovarian enlargement. Elevated levels of LH and androgen were noted. Hyperinsulinemia and acanthasis nigrans were seen. So this is what is acanthosis nigricans, and usually people developing this, they have a high incidence of moving towards PCOS or towards insulin resistance. They have velvety plaques on the nape of the neck or interdigitis area. So that is associated with insulin resistance. So sometimes overweight pre-diabetics also have this thing. What is happening in a PCOD is the impaired follicle development is leading to chronic anovulation or hyperandrogenism, which could lead to facial hair or hirsutism, skin changes or acne, alopecia, or thinning of hair on our head. And this could lead to insulin resistance, and insulin resistance could lead to hyperandrogenism, which both of the insulin resistance and hyperinsulinemia can lead to obesity, and vice versa, obesity leading to insulin resistance, increase in the extraglandular aromatization, and increase in the luteinizing hormone, and decrease in the FSH, which will reduce the fertility rate. So the most commonly used criteria is the Rotterdam criteria, hyperandrogenism, clinical or biochemical, the menstrual irregularities. That's why when we said that the normal menstrual cycle between 21 to 35 days. So when the cycles are delayed, when the cycles are happening more than 35 days, then eventually, instead of having nearly 11 to 12 cycles in a year, the cycles would come down. They would be less than 9 cycles per year, and they could be a delay of these cycles. So less than 9 cycles a year, and a confirmation on the ultrasonography of the woman. So here again there is insulin resistance, which is causing hormonal changes, which is responsible for PCOD or could lead to PCOD. Estrogen dominance is there, which could lead to a hypothyroid state, altered lipid profile state, and increase in the fat storage. So with insulin resistance, certain things like upper abdominal obesity, migrating aches and pains, fatigue after meals, craving for sugar, inability to lose weight, constant hunger, fatigue could be seen. One of the things with insulin resistance is they are not able to lose weight also so easy. So excess of weight, excess carbohydrate intake, sedentary lifestyle or genetics leading to insulin resistance. And with insulin resistance, we have an Pandora full of problems which we could be. So altered lipid profile, increased risk for blood clots, atherosclerosis, PCOD, sleep apnea, inflammation of the liver and cirrhosis, elevated triglyceride levels, hypertension, elevated blood sugar, increase of intra-abdominal fat, neurological changes, and cardiomyopathy could be there. So exercises which lead to alteration in a body composition are more beneficial as just compared to weight loss. So if we are able to build up our muscle and reduce the fat mass, so inch loss is there, even if the weight does not substantially come down, it will help us. Both endurance and resistance training exercise will decrease the fat mass. We will increase our resting metabolic rate with exercise. So even when we are not exercising, our metabolic rate is kept up. So we will be able to utilize whatever stores we have or whatever we are eating better. And a sustained weight management has to be kept in mind. A 10% increase in resting metabolic rate was seen in the diet and exercise group as compared to the nutrition group alone. So weight reduction will help decrease the glucose intolerance. It will improve in the reproductive and the metabolic derangements of PCOS. So significant improvement in the menstrual cycles was seen with exercise training, and weight loss reducing pulse amplitude of LH, in turn reducing androgen production and insulin resistance. Regular to moderate intensity aerobic exercise, even for short periods of time, improves the outcomes. So they should be exercising at least 90 minutes of aerobic exercise per week and going up to 60 to 70% of VO2 max. So we can follow a warm-up, a conditioning aerobic phase, and a progressive phases. After every 4 weeks, try to reach a new VO2 max. As we finish this slideshow, then I'll discuss something about an exercise logbook and how that helps us. So resistance training can be done for 2 to 3 days a week, and if done consistently for 3 to 6 months, beneficial effects would be seen. Just a slide or two about exercises and IVF. Mild to moderate exercises in overweight individuals have shown to improve the outcome of IVF cycles. Women preparing for IVF should not initiate a new cardiovascular exercise program at the time of initiation of her IVF cycle. But mild to moderate walking-based programs or not strenuous exercise programs can be encouraged. But there is a weak recommendation or a caution against strenuous exercises for women who are preparing for IVF cycles. So again, with PCOD, IVF, all exercises, the schedules are important. So what is happening in menopause is, there is a state when it's a normal reproductive life, that is the premenopausal years. Then gradually there is a perimenopause when the estrogen levels are coming down, then the menopause, and then the postmenopausal phase. So perimenopause is the time when there could be some disturbances in our menstrual cycle which could start. It could be we're having regular cycles, but 1 or 2 odd cycles where things could get either early or delayed. The flow of the period may change, and there could be changes within us which we may feel of irregular periods, weight gain, hot flashes, loss of libido, night sweats. All these could be there. It has been seen that women who exercise regularly from the perimenopausal years, they transition to the menopause with various somatic symptoms are reduced. Exercises have a benefit of elevating mood, acting as a stress buster, and keeping us in a happy state. So this transition is much more smoother in women who are consistent with their exercise program. Tell that women who exercise less, and when they enter menopause, they tend to gain weight easily and more than others. To complicate the matter, our metabolism also slows down with menopause. Menopause metabolism declines with age as the loss of the muscle mass is also decreasing. The muscles burn more calories than fat. So whenever the muscle is not preserved with weight training, the body simply does not burn as many calories. And the long-term sequelae of osteoporosis, sarcopenia, pathological neurological problems, cardiovascular events all tend to increase. So the exercises, so they will help to improve our flexibility, balance, cognitive function, physical function, reduce the medical risk of cardiovascular disease, high blood pressure, heart attack, stroke, increases the high density and the low density lipid levels, triglycerides, fibrinogen, they are all reduced. Both aerobic and strength training exercises are important. The exercises will have a reduced risk for dementia. So the bone strength, the bone mass increases with strength training activity. Something like people who are regular with walking or running, they offset the decline of bone mineral density and they prevent osteoporosis. Regular exercises reduces the menopausal symptoms and improve well-being. And with positive alteration of aerobic and resisted exercises, the lipid profile also improves. But what they need to keep in mind is to determine the maximum heart rate for exercise 220 minus the age. So they can start with having a target heart rate and multiplying it by 50% to start with. Gradually, after the first few weeks, bringing up the maximum heart rate to 75. We're multiplying it by 75 and improving their exercise schedule like that. So after 6 months or more of regular exercise, one is able to exercise comfortably at up to 85% of one's maximum heart rate. But those with recent ECG changes, myocardial infarction, uncontrolled arrhythmia, unstable angina, or any of these heart problems or uncontrolled metabolic problems, especially diabetes, they should be very particular about the exercise done under strict supervision. They should not follow all these regimes. They have to do what the body allows and how much they are supposed to do. So
ma'am, one thing, excuse me, ma'am, one thing I would like to ask you also. I mean, you said these things to be avoided, when the exercise should be avoided. Anything that in the don't, we have already covered the do's in the PCOD. What are the don'ts in PCOD that the patient with the PCOD should avoid doing?
The first thing in PCOD that they should be under medical supervision. There are a lot of young girls who realize they are having a problem. They sometimes share it with their mothers and they sometimes don't even share it with their mothers.
Right.
Even if they share it with their mothers, mother says,
they deny it. That is the denial.
They have to go to a doctor and get their hormonal levels checked. Because sometimes a lot of these PCOD girls, they are put on metformin. Metformin is an oral hypoglycemic agent. So they are put on that to improve their metabolism so that their weight also starts coming down. And once the weight is brought under control for the adolescent or the young teenage girl, then the cycles are also. Some of the PCOD cases, they require hormonal therapy. There have been cases when the girl has turned 16, she's not even had a menstrual cycle.
Menstrual periods.
And then they have delayed visiting the doctor till that time. And once they visit the doctor, they have to be put on hormones.
Hormone therapy,
have the normal cycles once the hormone done, once they're not taking the pills. So they are on oral contraceptive pills from a young age. But that is a part of the treatment which they have to follow. For them, it is important to be
under medical supervision, as you said.
Yeah. For everything that we are doing, exercises is an important part. It's not that exercises is the only thing.
Only part. That is the main part. That is one of the main parts.
Yes.
Please, yeah.
The bones become strong when the muscles attached to them become strong. Bone changes slowly, much slower than the strength changes in the muscle. So high load, low repetitions of compound exercises where we can work on our back, spine, hip, arms together, we will be able to improve our bone density. So it is regularity of exercises. It will help improve all our parameters, medical parameters, which would help us not to go into the metabolic syndrome. Improving the muscle mass, bone strength, coordination, balance, flexibility, quality of life, and reducing the risk of depression is all with regular exercises. Irregular exercises इसी में तो बहुत active बहुत exercise करती हूँ पर weight कम नहीं हो रहा. We all keep telling us after some time we all are saying that, but because maybe we are inconsistent and poor with our exercise routine. And when we are not exercising at all, so let us be prepared. So whatever detrimental effects will come on whichever part of our body, we should be able to face them. Not everybody, most of us have a little bit of erratic lifestyle, and there could be a genetic component on. We cannot do what genes we have. We already have them, we have to deal with them. So what is in our hand is we can improve the exercise component or the lifestyle component which we have. So when we say a slide, no God, no happiness. Either when we hear it, we can write it as no God and no happiness, or no God and no happiness. Similarly, no exercises, no results. Or no and do our exercises, and then only we will be able to know and see the results. So it's an attitude which will determine our direction. Thank you. So you were asking about exercises and menopause. So during the menopause, or with the onset of menopause, and both aerobic as well as resistance training exercises are important. So as a woman who is 45, 50 or 50 plus, if walking is done as a regular basis as an aerobic routine, or cycling or swimming is done as a lot of people are, that would cover up our aerobic component. And for resistance component, gentle weight-bearing exercises with weight at least 2 days a week is what is required to be done.
Thank you so much, Dr. Abha, for such an informative webinar. Good evening, everybody. Thank you each and every one of you for being here with us today. We are pleased to be able to welcome those of you who have been with us for years now, and as well as those of you who are new to this platform where IAP India helps creating free educational webinars. Special thanks to Dr. Sanjeev Jha, Dr. Ruchi Vashne, Dr. Nidhi, Dr. Sandhya, last but not the least, Dr. Abha, for organizing such educational webinars for upgrading the upgradation of physiotherapy in the field of medical line. I believe that IAP shall continue conducting such educational webinars and seminars for the professional at large. Thank you, everybody.
Thank you to Dr. Shikha.
Thank you.
Thank you very much.
Thank you, Dr.
Thank you,
Abha.
ma'am. Thank you, ma'am. Thank you, everyone. Thank you,
Thank you,
Dr. Deepti.
Dr. Shikha and Dr. Deepti. Thank you.
Thanks a lot. Thanks a lot.
Thank you.
Thank you so much.
Thank you so much, Abha ma'am, for such an informative session. On behalf of IAP technical team, I request to all participants, please subscribe our own IAP YouTube channel for watching more and more live webinar. Thank you. Thank you all.
Thank you.
Thank you, ma'am. Thank you, everyone.